Hello and good evening, everyone. So, how are you all doing? I hope all of you are fine and doing well. So, welcome to another live session on Eden 2. So, this live session we are conducting exclusively for our PSC aspirants, the ones who aspire for PSC assistant dental surgeon jobs. Okay, so today we will be discussing some of the general pathology questions from the previous year PSC question papers. Okay, so if you look at the previous PSC examination papers, you can see that almost like around, you can expect like an average of like 5 to 7 questions from general pathology alone. Okay, somewhere around like 6 marks or 6 questions weightage will be there for the PSC examination from general pathology. Usually, most of these questions will be factual questions, the one you have to attend from your memory, uh, the ones that test your memory. Yes, most of the questions will be like that. But in addition to that, you can also expect like true or false questions. All these statements given here are true about chronic inflammation, except, or all the statements given here are true about fat necrosis, except. Okay, such kind of questions also you can definitely expect in your PSC examinations. Okay. And when I went through the previous year question papers, there were rarely any application based or case based questions. Um, Maybe like one or two only I found out some kind of like application based or clinical based questions, like a patient who has echinosis granulosus. Okay, what kind of necrosis he will be having, like that. Okay, some kind of like clinical based or application based questions can be asked. Okay, but very rarely. Most of them are like usually straightforward one liner factual questions, but sometimes these one liner questions will be uh, can get difficult also, because they will be asking from the like, you have to understand the concept like or the subject very thoroughly to answer such questions. Okay, so such questions were asked in general pathology. And when I went through the previous year question papers, most of the questions, okay, the favorite topic of the examiners, I feel, was inflammation. Okay, the mediators of inflammation, the difference between acute and chronic inflammations, the features of inflammation, what you see in the acute inflammation, like the vascular events and cellular events, and what you see in the chronic inflammation, the granuloma formation, about the epithelioid cells, all those things, the questions were there. And the next favorite topic was definitely neoplasia. Okay. Rarely I had seen questions asking directly about the tumors, because that will be covered in oral pathology. In general pathology, they were like mainly concentrating on the etiopathogenesis of tumor. Okay, mainly the genes that are involved in carcinogenesis. Okay, so that can get a little bit tricky. So the proto-oncogenes and oncogenes and all, you must really know the basics about this genetics in carcinogenesis. That's very important, because there were questions, like 3 to 4 questions were like completely from this pathogenesis, especially this genetic mechanism that is involved in carcinogenesis. Okay, there were questions related to that. Okay, that can get a little bit tricky. And also about the hallmarks of cancer, there were questions. Okay, then the diseases of blood and lymph nodes. Okay, anemias, leukemias, and lymphomas. You cannot miss these 3 topics: anemias, leukemias, and lymphomas. How the red blood cell appears under the peripheral blood smear, and what is the histopathological appearance in the leukemia, the clinical appearance also, in which type of leukemia, which clinical features are seen, the lymphomas, the most favorite, Hodgkin's and the non-Hodgkin's, Reed-Sternberg cells and all. There are another favorite topic. And next is the fluid and dynamic disorder, the thrombosis, infarction, and embolism. Okay, along with that, the virtuous triad. Virchow's triad is like frequently repeated again and again in some of the question papers. Okay, so Virchow's triad is also important. Then coming to the basic chapters, that is in cell in health and disease, the necrosis and apoptosis. Necrosis, definitely you can expect one question related to necrosis and the common locations for each type of necrosis. From necrosis only, they were asking like clinical based or application based questions also. Like I had already mentioned, a patient suffering from echinococcus granulosus, what type of necrosis will be seen in such patient, like that. Okay. Then healing, definitely a difference between primary and secondary wound healing. A statement can be given and you may be asked to choose the right statement from the given statements that are given related to primary and secondary wound healing. Or the question can be like, what is the major difference between the primary and secondary wound healing? Like that also, they can ask the questions. Okay. Then miscellaneous topics, definitely infections, TB, hepatitis, and AIDS are really important. Please don't skip these topics. And genetics and syndromes. Okay, syndromes you can expect, and the karyotyping in the syndromes, like in Down syndrome, what is the karyotyping that you will see, or in the Turner's or in the Klinefelter syndrome, what is the karyotyping that you will see? Those all can be asked from general pathology. Okay, so these are some of the topics that you should definitely not miss while preparing your general pathology portions for your PSC examination. Okay, please do not skip these topics at all, especially inflammation and neoplasia. Definitely, one question can be expected from these first two topics, definitely. Okay, so let's move on to the first question. The principal action of prostacyclin or the PGI2 is, what is the principal action of prostacyclin? Is it chemotaxis or vasoconstriction or increased vascular permeability or vasodilatation? What do you think it is? For understanding the action of prostacyclin, first you should know about inflammation. What are the types of inflammation and what are the mediators of inflammation? You should know. Okay, so first let's have a look at what inflammation is. So inflammation means it is the response of a living tissue towards any external injury. Okay, so it is a local response of the living tissue to injury due to any agent. Okay, it can be a physical agent or a bacterial agent. Okay, so any kind of response that is given by the living tissue to an external agent, that is called as inflammation. It is kind of a defense reaction by the body against the external agent. Okay, so the body is trying to defend itself against the external factors. Okay, so that is called as inflammation. Now, based upon the duration of this inflammation, inflammation can be of two types. We have acute inflammation, which is generally of shorter duration, and we have chronic inflammation, which can go on for weeks or months. Okay, so these are the two types of inflammation. Now, if you look at this acute inflammation for the description purposes, it is mainly classified into two types. Okay, we have vascular events. Vascular events means there will be changes happening in the blood vessel. Okay, blood vessel dilatation, blood vessel constriction is happening. The vascular permeability is increasing, decreasing, like that. So many changes are happening in the blood vessels. Okay, so such changes are included under this vascular events. Next is the cellular events, that is the leukocytes. They are getting outside these blood vessels into the tissue. The diaperesis and the migration, pavementing, and all those phagocytosis by the inflammatory cells are all those included under these cellular events. So how these events are taking place? Okay, so there should be someone who is controlling these vascular events and cellular events in the acute inflammation. So what is controlling these vascular events and cellular events? So they are mainly controlled by some chemicals. Okay, so such chemicals are called as the chemical mediators of inflammation. Okay, so these chemicals can be released from the cells itself, that is from the plasma, that is from the inflammatory cells itself, or they can be released from the plasma, or they can be released from the injured or damaged tissue. Okay, so these chemical mediators of acute inflammation, we are broadly dividing into two types. One is cell-derived mediators, that is, they are like released from the inflammatory cells. Okay, then next we have the plasma-derived mediators, that is, they are released from the plasma. Okay, so these cell-derived mediators are of 6 types. We have the vasoactive amines, which include histamine and all. Then the arachidonic acid metabolites, lysosomal components, platelet activating factor, cytokines, and free radicals. Okay, so out of this, these arachidonic acid metabolites are an important chemical mediator. Okay, so you will find these arachidonic acid metabolites in the cell membrane. Okay, so in the cell membrane, you'll be able to see this arachidonic acid, which in the presence of phospholipases. Okay, in the presence of phospholipases, this arachidonic acid, it will get converted into arachidonic acid metabolites, and then it will again break down and form further metabolites with the help of two pathways. Okay, one is this cyclooxygenase pathway, and another one is this lipooxygenase pathway. In this cyclooxygenase pathway, it will form metabolites like prostaglandin G2, H2, prostacyclin, the one that is mentioned in the question. The prostacyclin, thromboxane, and PGD2 and PGE2 are all formed as a result of this cyclooxygenase pathway. Okay. Then under the lipooxygenase pathway, all the leukotrienes and lipoxins, they are all formed. Okay, so if you look at this action of this prostacyclin or PGI2, its main action is vasodilatation. That is, it helps in the dilatation of the blood vessels. Then the next action is inhibits platelet aggregation. So it will not allow platelet to get aggregated at a particular point of injury. Okay, so these are the main functions of prostacyclin or PGI2. Okay, so the question was, what is the main function or the principal function or principal action of prostacyclin? The main action is, it's not chemotaxis, no. It's not vasoconstriction, no. It is not increased vascular permeability, no. It is mainly involved in vasodilatation. Okay, so in this table here, you can see like the arachidonic acid metabolites, which are also called as eicosanoids, and their principal functions. Okay, so vasodilatation is not just the function of prostacyclin, prostaglandins and PGE1, E2 and D2 also helps in this vasodilatation. Vasoconstriction is done by thromboxanes and leukotrienes, and vascular permeability, leukotrienes, and the chemotaxis and this leukocyte adhesion is done by leukotriene B4, and smooth muscle contraction is done by this prostaglandins. Okay, so these are some of the local effects of these eicosanoids. There are systemic effects also present. Okay, so this our question was, what is the principal action of prostacyclin? I think now you got a clear idea about what are the chemical mediators of acute inflammation, what are the cell-derived mediators, what are the plasma-derived mediators, and in the cell-derived mediators, what are arachidonic acid metabolites, and in the arachidonic acid metabolites, we have the prostacyclin and what is its major function. Okay, so like that, you should generally have an idea about all the chemical mediators and their functions also. Okay, so it is given in this table here. You can refer this table for where this particular mediator is getting secreted from and what its actions are. Okay, so moving on to the next question. All are reactive oxygen species except which one of the following is not an reactive oxygen species? Yes, doctors, if you know the answer, you can put it in the chat box. Okay. So which one of the following is not a reactive oxygen species? So for that, we must know about what these reactive oxygen species are. Okay. So almost all the cells, they require oxygen for their function. Okay. Every cell requires oxygen for its function and for energy production. Okay. So almost 95% of the oxygen that goes inside the cell is utilized for its energy purposes and other purposes. Okay. But the remaining 5% of the oxygen, they are getting converted into metabolites. Okay. Like very unstable molecules. Okay. So such unstable molecules that are derived from this oxygen is called as reactive oxygen species. Okay. So these reactive oxygen species are nothing but they are the unstable molecules that contain oxygen and which easily reacts with any component inside the cell. Okay. They are what to say, an like an very reactive molecule. Okay, so they can like get reacted with any component inside the okay, they can damage any organelle inside the cells. Very reactive. Okay, so the mainly three reactive oxygen species are: one is superoxide, second one is hydrogen peroxide, and third one is hydroxyl radical. Okay, there is a fourth one called singlet oxygen, and there is something called as nitrous oxygen also, which are also considered as reactive oxygen species. But these are the mainly four ones. Among this, the singlet oxygen is like very difficult to find because it is highly reactive in nature and we cannot usually identify it inside the cell. Okay, but these three are really important: superoxide, hydrogen peroxide, and hydroxyl radical. They are really important. So in case if the cell encounters any radiation or toxins or reperfusions or something like this, some kind of injury or some kind of insult is there for the cell, what it happens is that there will be production of this reactive oxygen species. But this reactive oxygen species that is produced is like uh, readily removed. Okay, that is readily removed by the cells. Okay, the superoxide, it will get readily converted into hydrogen peroxide with the help of an enzyme that is called as superoxide dismutase. This hydrogen peroxide that will get converted to water by the enzymes like glutathione peroxidase and catalase, and hydroxyl radical also. It also gets converted to water with the help of glutathione peroxidase. Okay, there are enzymes that are there inside the cell itself that will readily convert this reactive oxygen species to very harmless products like water or hydrogen peroxide like that. Okay. Among these three reactive oxygen species, this hydroxyl radical is like the most dangerous one because it has the ability to produce pathological effects inside the cell. Okay, not just the hydroxyl radical, but all the reactive oxygen species, whether it is superoxide or hydrogen peroxide or the hydroxyl radical, if it is not getting converted to harmless products, then all these products has the ability to produce some kind of pathological effects inside the cell. Okay, so let's see what are the pathological effects it can produce. It can produce lipid peroxidation that will result in the cell membrane damage. Okay, it can affect lipids, proteins, and DNAs. Okay, so in the lipids, it can produce lipid peroxidation, which can result in damage of the cell membrane. Then proteins, it can result in the breakdown and misfolding of the proteins. And if for DNA, it can even cause mutations in the DNA. Okay, so this accumulation of reactive oxygen species inside the cell can produce some kind of pathological effects inside the cell, like cell membrane damage or the protein breakdown and misfolding can happen, or mutations in the DNA can also happen. Okay, so these three are the main reactive oxygen species, and these are the pathological effects that it can produce. Okay. Now, next question. Which of the following is a feature of chronic inflammation? Okay. So till now, we had discussed everything about the acute inflammation, the mediators of acute inflammation, and about reactive oxygen species and the free radicals also. Now, let's move on to chronic inflammation. What is the typical feature that you see in chronic inflammation? Is it keloid? Keloid is a complication of wound healing. Okay. If the wound healing is not proper, then it can result in the formation of keloid. Suppuration or pus formation is a feature that you see in acute inflammation. Granulation tissue formation is what you see in wound healing process. Okay. Then option D, granuloma. Okay, yes. So granuloma is the typical feature that you see in chronic inflammation. So chronic inflammation, like I had already mentioned, it is an inflammation or a response of prolonged duration. It can like get prolonged, be there for weeks or months. And the characteristic feature of this chronic inflammation is you will be able to see three types of characteristic features in this chronic inflammation. One is you will be able to see the typical inflammatory process in the chronic inflammation with the help of chronic inflammatory cells like macrophages, lymphocytes, and mast cells. Okay, you'll be able to see such cells in the area of chronic inflammation, which includes macrophages, lymphocytes, and mast cells. And next is the tissue injury. Okay, there will be definitely tissue destruction happening in chronic inflammation. And next is the body will try to repair the injured tissue. Okay, so the three features that you will definitely see in chronic inflammation is one is inflammation with the chronic inflammatory cells. Okay, you will not be able to see neutrophils here. Okay, neutrophils are acute inflammatory cells. Okay, so they'll be present only in acute inflammation, whereas this is chronic inflammation. So you'll be able to see chronic inflammatory cells like macrophages, lymphocytes, and mast cells. The next one is some kind of tissue destruction or tissue injury will be seen in the form of maybe necrosis like that. Okay. And then the third one is attempt of healing. Okay. There will be angiogenesis, that is blood vessel formation, and fibrosis. Okay. Lots of fibers will also be seen. Okay. So these are the three features of chronic inflammation. Now, these chronic inflammation can be divided into two. Okay. One is chronic non-specific inflammation. That kind of inflammation that you see in osteomyelitis and in lung abscess, they are the examples of chronic non-specific inflammation. Okay. And next one is the chronic granulomatous inflammation. So what is the typical feature that you see in this chronic granulomatous inflammation is that there will be granulomas seen under the microscope. Okay. So if you take a biopsy from that particular site, okay, and you stain it and look at it under the microscope, you will be able to see lots of granulomas under the microscope. Okay, so that is a feature of chronic granulomatous inflammation. Now, such kind of inflammation is usually seen in tuberculosis, leprosy, syphilis, actinomycosis, sarcoidosis, and okay. So how this granuloma is getting formed, let's have a look at it. In case of any cell injury or in case if any bacteria attacks our body and comes inside our body, there will be definitely the acute inflammation that is trying to eliminate it, but the bacteria or the stimulus will be so strong that the acute inflammation cannot destroy it. Okay, so what it does is that it will activate T cells. Okay, T cells are much more organized and they have like much more defense power also. Okay, so what it does is that it will, these T cells, it will again activate the macrophages and it will try to digest or phagocytose this particular microorganism. Okay, but it will not be able to fully degrade that particular microorganism. Okay, so what the body does is that it will produce something like a prison. Okay, it will produce something like a prison and try to contain this particular microorganism inside this prison. Okay, so this prison-like structure that is formed by our defense cells of the body, they are called as this granuloma. They form this granuloma formation. Okay, so what is mainly happening in the granuloma is that our defense cells, they cannot completely eliminate the stimulus. So what it does is that it is trying to contain that stimulus in a particular area. Okay, without allowing it to spread further. Okay, so that is what is mainly the pathogenesis behind this granuloma. So in the granuloma, you'll be able to see lots of inflammatory cells, like there will be macrophages will be seen, epithelioid cells will be seen, lymphocytes will be seen, and multinucleated giant cells will also be seen in case of this granuloma. And at the surroundings, you will be able to see lots of fibers and blood vessels will also be seen. Okay, in the center, sometimes in a long-standing granuloma, necrosis can be also be seen in the center. Okay, so I think you got an idea about the granuloma formation, and this is the pathogenesis behind the granuloma. Okay, so next question, it is again related to the chronic inflammation. The epithelioid cells are, so what are these epithelioid cells? Are they modified epithelial cells, or are they modified endothelial cells, or they are activated macrophages or transdifferentiated lymphocytes? Epithelioid cells, look at the name, epithelioid. Epithelioid means something that ends with OID means it is resembling the epithelial cell. Okay. So something that ends with OID means it is resembling some other type of cell. Okay. Like osteoid. Osteoid means bone-like. Here, epithelioid means epithelial cell-like. Okay. They are not exactly epithelial cell. They are epithelial cell-like. Okay. So, what do you think is the correct option here? Are they modified epithelial cells? No, they are actually macrophages only. But these macrophages will look like epithelial cells. Okay, so that's why it is called as epithelial-like cells. Okay, actually they are macrophages only, but they look like epithelial cells. That's why they are called as epithelioid cells. So let's see how these epithelioid cells are forming in this chronic inflammation. So as I had already mentioned, granulomatous inflammation, it is a form of chronic inflammation which is formed due to macrophages, lymphocytes, and you'll be able to see lots of giant cells also. Okay, sorry. Okay, so what happens is that these macrophages will be recruited to the site of inflammation. So these macrophages, they get activated. And once they get activated, what it does is that it will develop lots of cytoplasm. Okay, it will develop like abundant cytoplasm. When it develops like abundant cytoplasm, it starts resembling like epithelial cells. Okay, it starts resembling like epithelial cells. That's why it is called as epithelioid cells. Okay, so this is a histopathological picture of chronic inflammation of a granuloma particularly. So you will be able to see such large pink colored structures with like dots at the periphery. Yes, these are the giant cells. Okay, giant cells with lots of nucleus. Yes, they are the giant cells. Then the central area, you'll be able to see necrosed areas. Then at the near the necrosed areas, you'll be able to see such cells with lots of cytoplasm which resemble epithelial cells. They are called as the epithelioid cells. Epithelioid cells are activated macrophages. Okay, they are not modified epithelial cells. No, they are activated macrophages. Okay, and at the surrounding, you'll be able to see lots of this blue color dots you see. Yes, that are the lymphocytes. Okay, then surrounding it, you'll be able to see lots of collagen fibers also. Okay, so this is a typical appearance of granuloma and what epithelioid cells are. Now, next question. False statement about secondary healing is. What is a false statement? It is more intense. It has more intense inflammation than primary healing. It has greater volume of granulation tissue than in primary healing. It has greater mass of scar tissue compared to primary healing, or it has minimal wound contraction. Yes, what is the false statement here? They are asking for the false statement. Okay, so first you have to know about the wound healing process. Okay, so wound healing process can take place by two process. There is healing by primary intention, or which is also called as primary union, and there is healing by secondary intention, which is called as secondary union. Okay, so in primary union, if you look at the wound, okay, if you look at the characteristics of the wound, it will be a very clean and not so infected wound. Okay, it is not an infected wound and it will be a clean wound, and there is like the loss of tissue and the loss of cells is like very minimal, and you will be able to approximate the edges of the wound also with the help of a suture. Okay. So these are the characteristics of a primary wound. A primary wound will be usually clean, not infected, only like very less amount of tissue loss and the cell loss will be there, and you can approximate the edges of the wound together with the help of sutures. Okay, so these are the characteristics of a primary wound. Now next is the secondary wound. Secondary wound is just like just the opposite of primary wound. It will be infected, it will be a large wound, and you cannot approximate the edges of the wound also. And so that are the characteristics of the secondary type of, okay, just the opposite to the primary wound. You will be seeing the characteristics of the secondary wound. Now let's have a look at this primary union and the secondary union, that is healing by the primary infection and healing by the secondary infection. What are the characteristics features? Cleanliness, yes, primary wound will be clean whereas secondary will be unclean. Infection, primary is usually uninfected whereas secondary may be infected also. Inflammation is mild in case of primary union whereas it will be more intense in case of secondary union. Okay, so the first point they mentioned was the more intense inflammation than primary healing. Yes, secondary union has more intense inflammation than primary healing. That's a true statement on it. Then next have a look at the granulation tissue. It will have a scanty granulation tissue, whereas the granulation tissue is much larger in case of secondary union. So let's have a look at the option B, greater volume of granulation tissue than in primary healing. Yes, that's also correct. Secondary healing will produce much larger amount or greater volume of granulation tissue when compared to primary healing. And next is wound contraction. It is not present, whereas it is present in case of secondary union. Okay. So in the secondary union, since the granulation tissue is very large, this granulation tissue contains some special cells. They are called as myofibroblast. Okay. So this myofibroblast will try to contract the wound as much as possible. Okay. So if you look at it, this myofibroblast will try to contract it to 1/3 to 1/4 of the original size of the wound. Okay. So the wound contraction will be very large in case of this secondary union. It's not just a minimal wound contraction, but about 1/3 to 1/4 of the original size of the wound is getting contracted in case of this secondary healing. Okay, so option B, this minimal wound contraction is not it is the only false statement regarding secondary healing. So the outcome of the primary healing, it will be a neat linear scar, whereas it will be an contracted irregular wound in case of secondary healing. And the complications of the primary healing are usually very rare. Sometimes epidermal cyst formation can be seen. And secondary union, the complications are more frequent, and the most common one is separation, pus formation. Okay. So that's all about primary healing and secondary healing. Okay, now next, let's move on to the next question. Which of the following is not a component of Virchow's triad? Okay, this question is really important because it's been repeated. Okay, 1 or 2 times it's been repeated for the PSC examination. So please make sure that you learn about this Virchow's triad and thrombosis and embolism thoroughly. Okay, so Virchow's triad, which is not a component. Okay, so for that, let's have a look at what this Virchow's triad is. So before going to Virchow's triad, let's have a look at what this thrombosis is. Okay, thrombosis is the formation of a mass of tissue inside the blood vessels. Okay, so a mass like this is formed inside the blood vessels. Okay, so that is called as a thrombus. And this process is called as thrombosis. Okay, so this thrombus is formed by the constituents of the blood itself. That is, from the blood cells or from the blood components only, this mass is getting formed inside the blood vessel. Okay, so this is called as a thrombus, and this process is called as thrombosis. Now, while conducting experience on what are the causes for this thrombosis, Virchow find out that there are 3 main factors. that are contributing to this thrombus formation inside the blood vessel. Okay, so he named the Virchow's triad. Okay, so what are the three main factors? One is endothelial injury. Okay, the main one and the important one. Okay, so the integrity of the blood vessel and the endothelial injury is the main factor that is contributing to this thrombosis. Next is the abnormal blood flow, and the last one is the hypercoagulability of blood. Okay, so endothelial injury means what is happening is that this is the endothelial cells. Okay, this pink colored structure, parallel line, yes, that is the blood vessel, and the cells that are lining this parallel line, yes, that are the endothelial cells. Okay, so when some kind of injury happens in this region, what is happening is that under the epithelium or under these endothelial cells, there will be connective tissue present. Okay, so the subendothelial connective tissue is getting exposed because of this vascular injury. So when it gets exposed, what happens is that the platelets will try to come and like seal off that injured part. Okay, so there will be platelet coming, which will result in platelet adhesion. Then there will be release reaction. There will be release of granules from the platelets, and it will result in platelet aggregation also. Okay, which can further contribute to hemostasis and thrombosis. Okay, so this is how a normal non-activated platelet will look like with its own platelet granules and all, like the alpha granules and the dense granules and all will be present inside the platelets itself. Once it get activated, what it happens is that the pseudopores will be formed and the canalicular system will also be very deep in nature, and it will start releasing granules. The alpha granules and the dense granules, it will be released to outside. So when these granules are also released, the other platelets also identify it and will come and form an aggregated structure like this on that injured area. Okay, so minimal aggregation is very helpful to seal off the blood flow, but if the aggregation keeps on happening and happening, it will result in something called as thrombosis. Okay, so that is how endothelial injury is contributing to this thrombosis formation. Now, next topic, the next factor in the Virchow's triad is the abnormal blood flow. Okay, so you see this picture here. This is how the normal blood flow is. Okay, the leukocytes, the red cells, and the platelets, they will be in the center, and at the periphery, you will have the plasma. Okay, so plasma will be at the periphery. The cells will only go through the center. Okay, but in case of abnormal blood flow, because of some turbulence or because of stasis. Okay, so turbulence means there's a chaotic blood flow, or because of slowing down of blood, what happens is that it will create an abnormal blood flow like this. Okay, so this is the normal one. This is the abnormal one. You can see in the abnormal one, the cells are getting like the cells are everywhere. Okay, they are hitting in the endothelial cells also. Okay, so that can result in injury to the endothelium. So again, endothelial injury, the subendothelial connective tissue is getting exposed, platelet aggregation, all the factors that we already told in the endothelial injury. Yes, that can happen again in the turbulent stage, and it can result in arterial and cardiac trauma. Okay, in case of stasis, what is happening is that there will be slowing down of blood, which will release lots of oxygen from the blood. Okay, so that can result in venous thrombi. Okay, in the injury to the endothelial cells are not usually seen in the stasis, but still it can contribute to the formation of the venous thrombi. Okay, the next is hypercoagulability of blood. Okay, so in the hypercoagulability of blood is usually seen in thrombosis that happens in the nephrotic syndrome or in the advanced cancers, in extensive trauma, in burns and all, we'll be able to see hypercoagulability of blood. Okay, so this because of this hypercoagulable blood, what is happening is that the coagulation factors are more and more released. The platelet count is released and their adhesiveness is also increased, and the coagulation inhibitors are decreased. Okay, so all these three factors leads to thrombosis formation because of hypercoagulability of blood. Okay, so Virchow's triad, endothelial injury, abnormal blood flow, which includes turbulence and stasis, and hypercoagulability of blood. Okay, so these are the three factors that are mainly involved under Virchow's triad. Okay, thrombocytopenia is not a feature of Virchow's triad. Now, next question. Fibrinoid necrosis is usually seen in. Where will you see fibrinoid necrosis? Okay, so in the brain, usually you'll be able to see liquefactive necrosis. Tuberculosis, you'll be usually able to see caseous necrosis. And in the heart, you'll be able to see coagulative necrosis. Okay, so because any kind of immune complex necrosis, there you'll be able to usually see fibrinoid necrosis. Okay, so what do you mean by necrosis? Necrosis is a localized area of death of tissue, and it is followed by degradation of the tissue by the enzymes that are secreted from the dead cells itself. Okay, so death of tissue followed by degradation of the tissue by hydrolytic enzymes from the dead cell itself. So this necrosis is of 5 types. We have the coagulative necrosis, liquefaction necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. So mostly in heart, spleen, and kidney, you'll be able to see coagulative necrosis. In the brain and in case of abscess cavities, you'll be able to see liquefactive necrosis. In any type of necrosis in the pancreas and breast, that would be usually fat necrosis. And in tuberculosis infection, you'll be able to see caseous necrosis, because in the center it will release some like cheesy like material will be seen, so it will be called as caseous necrosis will be seen. Okay, in case of any immunological tissue injury, okay, because of some immune complex vasculitis or in autoimmune disease or in Arthur's reaction or in the hypertension or in peptic ulcer, what you will be able to see is that these kind of antigen antibody complexes, they will get deposited in the blood vessels like this. Okay, so this is a blood vessel, and these immune complexes, it will get deposited in the blood vessels like this. Okay, so it will produce a bright pink deposit like this. If you look under the microscope, you'll be able to see a bright pink deposit like this in the blood vessel. Okay, so this bright pink material, it is called as fibrinoid or fibrin-like material. Okay, so that's why this necrosis is called as fibrinoid necrosis. Okay, so I hope you are clear about the necrosis, its sites, and what all you see under fibrinoid necrosis. Now, next question. The most commonly mutated proto-oncogene in human tumors is, okay, so here comes the genetics in carcinogenesis. Okay, genetics in cancer formation and genetics in tumor formation is a little bit complex topic. The more you study, the more complex can it get also. So, but you should understand the basics about this genetics in carcinogenesis or genetics in tumor formation, because questions were like frequently asked from these topics for your PSC examinations. Okay, so today I'll discuss some of the basic that is related to genetics in tumor formation. Okay, so let's have a look at the genes that are involved in cancer formation. Okay, mainly 4 types of genes are involved in cancer formation. One is proto-oncogenes or oncogenes. Okay, proto-oncogenes or oncogenes, just like the name suggests, they are the ones that are usually present in our cell, in an inactive form. Okay, this inactive form of this gene is called as proto-oncogene. Okay, but this proto-oncogene, because of some chemical or physical or some biological factors, if it is getting mutated and if it is forming oncogene, this oncogene will produce oncoproteins. These oncoproteins are capable of like producing tumor in cells. Okay, so that is the main function of this oncogenes. Okay, so oncogenes or proto-oncogenes. Okay, the prototype of this oncogene is called as the proto-oncogene. These proto-oncogenes are normally present in our cells. Okay, but they will be in a inactive manner. Okay, but when it's get activated because of some physical, chemical, or biological agent, then what happens is that they will get converted into oncogenes. These oncogenes will produce something called as oncoproteins. These oncoproteins have the capability to produce tumor in a particular cell. Okay, so first is oncogenes. So if you activate these oncogenes, it can lead to tumor formation. Okay, so first is activation of oncogenes. Okay, the next is there are some other genes, there are some other set of genes that are called as the tumor suppressor genes. Okay, just like the name suggests, they are the genes which suppresses the tumor. Okay, so there are tumor suppressor genes or anti-oncogenes. Okay, they can be called as anti-oncogenes also, but usually we use the term tumor suppressor gene. Okay, so these tumor suppressor genes are also there. Their main function, just like the name suggests, their main function is to suppress the tumor formation in cells. Okay, so if these tumor suppressor genes, if they get inactivated, okay, so they are like the what to say, like the police or the defense system in our country. Okay, so if the defense system is like suppressed, then anyone from outside can attack us and can lead to tumor formation. Okay, so activation of oncogenes and inactivation of anti-oncogenes or inactivation of tumor suppressor genes. Okay, so these are the main two mechanisms that are involved in tumor formation. Okay, then there is a third set of genes that is called as genes regulating apoptosis. Okay, apoptosis means programmed cell death. Okay, every cell, when it becomes old or when its function is over, it should undergo apoptosis or programmed cell death. That is, it should undergo death. Okay, but sometimes what happens is that if there is any mutation in the genes that are regulating this apoptosis, then these cells will not undergo apoptosis and they will keep on multiplying, and it will result in the tumor formation. Okay, so that is the genes regulating apoptosis. Then the fourth set of genes that are involved is the genes that is regulating the inflammation between tumor and host cells. Is like very much advanced. We don't have to discuss that. So remember the three set of genes that are involved in cancer formation. One is oncogenes. So activation of oncogenes can lead to tumor formation. Then the second one is tumor suppressor genes or anti-oncogenes. Okay, so the inactivation of these tumor suppressor genes or anti-oncogenes can lead to tumor formation. And the last one is the genes regulating apoptosis. Okay, any mutation that is happening in this genes regulating apoptosis, it can also lead to tumor formation. Now let's have a look at this oncogenes. Okay, so these are the 5 oncogenes that are present in our body. We have the growth factors, which include the TGF beta and FGF beta, the fibroblast growth factor, and all those growth factor genes will be there. Yes, they are the oncogenes. Then the receptors for the growth factors, okay, where they are going and getting attached. Okay, they any kind of mutation in that also can lead to tumor formation. The epithelial growth factor receptor and all. And next is the cytoplasmic signal transduction proteins, which include the RAS gene. Okay, this is very important because it includes the RAS gene and the BCR-ABL fusion gene. Okay, so this RAS gene and then the nuclear transcription factors, the that includes the c-MYC, n-MYC, and l-MYC, and the cell cycle regulatory proteins. Okay, so the cell cycle has some kind of regulatory proteins which are called as the cyclins. Okay, so the cyclin D, E, and CDK4 are all involved in regulating the cell cycle. So if any kind of damage is happening to those genes, it can result in a aberrant cell cycle that can lead to tumor formation. Okay, so these 5 are the groups that are involved under oncogenes. Okay, so if these oncogenes are getting activated, it can lead to tumor formation. Okay, so in the question it was asked, which is the most commonly mutated proto-oncogene in human tumors. Okay, so the most commonly mutated proto-oncogene in the human tumors is this RAS gene only. Okay, so this RAS, it was for the rat sarcoma gene. Okay, because these genes were first isolated in a sarcoma of the rat, so it was called as rat sarcoma gene. So around like 30% of all the human tumors contain this mutated RAS gene. Okay, so they are usually seen near this GDP and GTP. Okay, so this GDP is guanosine diphosphate and GTP is the guanosine triphosphate. Okay, so this inactive form of RAS, it will be bound to the GDP here. But as it becomes active, okay, it will be bound to the GTP. Okay, even if it gets active, there are like mechanisms in our body itself to make it inactive. Okay, so it will release some enzyme that is called as the GTPase, which will make this activated RAS inactive. Okay, so this is the inactive RAS and this is the active RAS. But in case of some kind of mutation is happening in this RAS, for example, some kind of point mutation is happening in this RAS, then what happens is that it will get activated and this GTPase, it cannot degrade this RAS. And what happens is that it will activate further the RAF pathway and the MAPK pathway, and it will lead to release of MYC protein. Okay, lots of MYC protein are released and it can lead to cell proliferation. It signals the cell proliferation and it helps in the progression of the cell cycle also. Okay, so that's how the tumor is getting formed with the help of this mutated RAS gene. Okay, and this mutated RAS gene is the most common mutated oncogene that is present in human tumors. Okay, around 30% of all the human tumors that you take, it will have this mutated RAS gene. Okay. So next question. Among the following, which of the following is a proto-oncogene? So we had already discussed about oncogenes, tumor suppressor genes, and genes that are regulating apoptosis. Okay. So this, excuse me. So this primitive type or the inactivated oncogene, that is called as this proto-oncogene. Okay, so which of the following here is a proto-oncogene they are asking? Is it P53 or RB or APC or CERBB2? Okay, so this P53, RB and APCs are tumor suppressor genes or they are the anti-oncogenes. Okay, so the one that is a proto-oncogene is option D, CERBB2. I'll tell you in detail because it can be confusing for you. So these are the, in the last question, we had discussed about the oncogenes and when it get converted to like when it get converted to oncoproteins, what is the tumor formation and all that we discussed. Here, let's have a look at the proto-oncogenes. Okay, here we are discussing the same 5 oncogene families only. The growth factors, the receptors for growth factors, and the cytoplasmic signal transduction proteins, and the nuclear transcription, and the cell cycle regulatory proteins on. Okay, so here we are discussing in detail what are the proto-oncogenes involved also. Okay, so for the EGF receptors, there are proto-oncogenes like ERBB1 and ERBB2. Okay, so this ERBB2 or which is also called as HER2. Okay, so this HER2 is really important because if you look at almost 20% of the patients with breast carcinoma, you'll be able to see this gene mutation. Okay, so for genetic analysis of the patients also, like whether we are going to get breast carcinoma in the future. Okay, that can also be analyzed with this ERBB2 or HER2 gene mutation. Okay, it can predict the possibility of having a breast carcinoma in future also. Okay, so this EGF receptors contain proto-oncogenes which are called as ERBB1 and ERBB2. So these are the only proto-oncogene that is present among the following. Okay, so like I had already mentioned, proto-oncogene will get activated and it will form oncogene. It will produce oncoprotein, and this oncoprotein only promotes the cell growth. Okay. So the proto-oncogenes, the 5 proto-oncogene families we had mentioned, and in the growth factor family only, we have the epidermal growth factor, which contains ERBB1 and ERBB2, which is also called as HER2. Okay, so this ERBB1, it is usually overexpressed in 80% of the squamous cell carcinomas of the lung and in the epithelial tumors of the head and neck region also. Okay, this ERBB2 or HER2, their mutation is usually seen in breast carcinomas. Okay, so it is for the targeted therapy. Okay, for the treatment of breast carcinoma nowadays, like the investigators are using this anti-HER2 antibodies also. Okay, so when this gene mutation is like neutralized, then the patient has shown a decrease in the symptoms of this breast carcinoma. Okay. Now, next question is again gene related. P53 acts as a tumor suppressor by following mechanisms except. Okay. So for that, we should know what this P53 is and what is its mechanism of action. Okay. So like I had already mentioned, cancer genes are of 4 types: oncogenes, tumor suppressor genes, and the genes regulating apoptosis, and the genes regulating the interactions also. So out of this, oncogenes we had discussed in the past 1 or 2 questions. Next, we are coming to this tumor suppressor genes. Okay, so the tumor suppressor genes include APC and beta-catenin proteins, TGF, beta, RB, P53, and BRCA1. Okay, so out of all these tumor suppressor genes, the ones that are important is this RB, which is also called as retinoblastoma gene. Okay, very important. And the next one is this P53. Okay, P53 is also very important. So this RB or retinoblastoma gene, it is also called as the governor of the cell cycle. And this P53 is also called as the guardian or the protector of the genome. Okay, let's see why it is called as this guardian of the genome. Okay, so if you look at it, this P53 gene, it is usually present in the chromosome number 17. Okay, so what happens is, usually what is the function of this P53 is that during cell division, okay, a cell division is going on. You have seen the cycle of cell division and all with G0 phase, G1 phase, G2 phase, M phase, and S phase. Yes, there is a cycle of cell cycle that is going on like that. The cells will go through each phase and it will replicate. Okay, so that is the basic mechanism of cell cycle. Now, during this cell cycle, what can happen is that sometimes there will be damage that will happen to the DNA. Okay, so in case some kind of damage is happening to this DNA, there must be someone to analyze it. Okay, so that analyzing function is mainly done by this P53 only. Okay, so in a normal cell, this P53 will be present in very small amounts only. But in case if some kind of DNA damage is happening inside the cell, then you will be able to see lots of P53 in that particular cell. Okay, in that particular cell cycle process also. Okay, lots of P53 will be there. So the main function of this P53 is that to detect the damaged DNA. Okay, once it detects the damaged DNA, what it does is that it will just pause that cell. Okay, it will just stop that cell in the cell cycle. Okay, that P53 will not allow that cell to go into G1 phase. Okay. Okay, so that is the main function of this P53. Okay, it will just pause the cell in its cell cycle. Okay, and then it will activate the DNA repair genes. Okay, and it will activate the DNA repair genes, and its DNA repair genes, they will come and try to repair this damaged DNA. Okay, since the cell cycle is paused, it will be very easy for them also. Okay, so these repair genes, they will come and try to repair this damaged DNA. Okay. If it is able to repair, then the P53 will again analyze it and it will like ask the cell to continue the process. Okay, it will not stop it. It will ask the cell to continue the process like in the previous ways. Okay, so that is one function of P53. And another function of P53 is that if the DNA repair genes, they are not able to repair the damaged DNA. Okay, if they are not able to repair the damaged DNA, then what it does is that it will push that cell towards apoptosis. Okay, apoptosis is programmed cell death. It will identify that this cell has a damaged DNA and it will like take a decision that we don't want this cell to get proliferated. So what it does is that it will push that particular cell to apoptosis or programmed cell death. Okay, so these are the two main functions of P53 that is happening in a normal cell. Okay, so since this P53 is the one that is like determining whether the DNA is damaged or not, and if it is damaged, it is taking its action, particular action to like repair that damage or to push the cell towards apoptosis. So that's why this P53 is called as the guardian or the protector of the genome. Okay, because it is like actually protecting the DNA material. Okay, so how this P53 acts as a tumor suppressor. Okay, we'll have a look at it. So like I had already mentioned, in cell division, there will be DNA damage happening. So if there is a DNA damage happening, then the P53 will identify it and it will come and stop the cell cycle. Okay, it will come and just stop the cell cycle just like that, and it will give like a breathing time for the cells. Okay, so this temporary arrest of the cell cycle, that is called as quiescence. Okay, there's a particular word for it. It is called as quiescence. Okay, in case of any damage or in case of any mutation is detected in the DNA, P53 will come and stop or arrest the cell cycle temporarily. Okay, so this temporarily arrest of cell cycle, that is called as quiescence. Okay, once this quiescence happens, what is happening is that the DNA repair genes will come. Okay, and they will release proteins and it will try to repair the damaged DNA. Okay, when it tries to repair the damaged DNA, if the DNA is getting repaired, it's well and okay, no problem. But if it is not getting repaired, then what this P53 does is that it will permanently arrest the cell cycle. Okay, earlier it was just the temporary arrest of cell cycle, but if the DNA damage repair genes, they also cannot repair the DNA, then what it does is that it will permanently arrest the cell cycle. Okay, so that is called as the senescence or P53 induced senescence. Okay, now once this permanent cell cycle arrest is happening, the next ultimate protective mechanism that this P53 does is to induce apoptosis. That is, P53 recognizes that this cell has a mutated DNA and it cannot be repaired. So what it does is that it will push that cell towards apoptosis. Okay, with the help of pro-apoptotic genes like BX gene and all, it will release the apoptotic factors and it will push that particular cell towards apoptosis or cell death. Okay, so this is how the P53 usually acts. Okay, so the quiescence is the temporary cell cycle arrest. Senescence is the permanent cell cycle arrest, and it will also promote the P53 induced apoptosis also. Okay, so that is the ultimate protective mechanism that is done by this P53. So in case if there is no P53, what will happen is that no cell cycle arrest will be there, no DNA repair will be there, no senescence will be there, the cells will get mutated and it will form a malignant tumor like this. Okay, so in the question, it was asked, which of the following is a mechanism? All of the following are mechanisms by P53 except, that is, which of the following is not a mechanism of P53? Quiescence, yes. Senescence, yes. Induction of apoptosis also, yes. But option C, downregulation of catenin. No, that is not done by P53. Okay. So I hope you are all clear about what this P53 is, how this P53 works, and why it is called as the guardian of genome. Okay. Now moving on to the next question. Gum hypertrophy is seen in. Where will you see, in which type of leukemia will you see this gum hypertrophy? Okay. Yes, for that, let's have a look at the WBC, or the white blood cell neoplasm. Okay, so the white blood cell neoplasm are divided into three types. We have the lymphoid neoplasm, which include acute lymphoblastic leukemia and chronic lymphoblastic leukemia and all. Then we have this histiocytic neoplasm, which include Langerhans cell histiocytosis. And the third one, we have the myeloid neoplasm. Okay, which include the acute myeloid leukemia, chronic myeloid leukemia, the myelodysplastic syndromes and all. Okay, so in this acute myeloblastic leukemia, a classification was given by WHO and FAB. Okay, FAB means French American British classification. Okay, so this table here gives the FAB classification of acute myeloid leukemias. So in this FAB classification, this AML is classified from M0 to M7. Okay, based upon its histopathology and based upon its cytochemistry. Okay, so M0 is the minimally differentiated type of AML, whereas M7 is the differentiated type of the very much differentiated type of AML is seen here. Okay, so out of all these types, this M4 and M5, okay, remember the classes, M4, which is the myelomonocytic type, and M5, which is the monocytic type. Okay, only these two types show gum hypertrophy. Okay, so these are all like leukemia-induced gum hypertrophies. Okay, so this leukemia-induced hypertrophies may be diffuse like this, or it may be a tumor-like growth like this. Okay, it can be diffuse like this, or it can be a tumor-like growth like this can also be present. Okay, so how these leukemia or leukemic cells are producing this gingival enlargement? It's because these leukemic cells, they are getting infiltrated into these soft tissues, oral soft tissues, and it will produce a diffuse, boggy, non-tender swelling like this. Okay, so this is a hemorrhagic swelling. That's why this color. And this type of swellings that you see in the acute myeloid leukemia patients, they are called as the myeloid sarcoma. Okay, earlier it was called as chloroma. Okay, because when you cut this tissue, a green color is seen. Okay, so that's why it was earlier called chloroma. But now that word is not used. Now we use the word myeloid sarcoma. Okay, so gum hypertrophy is seen in only two stages of AML. One is M4 and M5. Since M4 is not given here, so we are going with the most appropriate option, that is M5. Okay, acute myeloid leukemia, M5. The next question, chromosomal abnormality that is associated with chronic myeloid leukemia is, okay, the chronic myeloid leukemia has a special chromosome that is seen, which is called as the Philadelphia chromosome. Okay, so let's see how this Philadelphia chromosome is getting formed. There is normal chromosome 9 and there is normal chromosome 22. Okay, so in the chromosome 9, it has a region called ABL region. Okay, so this ABL region is named as Abelson-Murin, named after Abelson-Murin leukemia virus. It is called as ABL gene. And then we have in chromosome 22, which we have a particular region that is called as the BCR point, which is also called as breakpoint cluster region. Okay, so in chronic myeloid leukemic patient, what is happening is that in the chromosome number, there is translocation of this ABL to this chromosome number 22. Okay, so this ABL region in 9 is getting translocated and it is coming to this chromosome number 22 and it is forming a fusion gene here. Okay, so that fusion gene that is formed in this CML, it is called as this BCR-ABL fusion gene. Okay, so such type of a mutated chromosome that you see in CML, it is called as Philadelphia chromosome. Okay, so in Philadelphia chromosome, what you will mainly see is that there is 9 and 22 chromosome translocation is there. Okay, so remember this 9 and 22 translocation is usually seen. Now, because of this BCR-ABL fusion gene, it will produce BCR-ABL fusion gene products or proteins will be formed. Now, these proteins have the capacity to inhibit apoptosis, and they also have the capacity to alter the anti-oncogenes, okay, or the suppress the anti-oncogenes. Okay, so that will lead to formation of chronic myeloid leukemia. Okay, so only this CML have this particular variety of gene mutation among the leukemias. So remember that. The next question, which of the following findings is seen in the red blood cells in megaloblastic anemia? Okay. Findings seen in the red blood cells. Okay, not the neutrophils or the other cells, only in red blood cells, what you will be seeing. Macropolycyte or Dolly bodies, Cabot rings or Dutcher bodies. Okay, for this you have to know what are the bodies are, what is seen here. Okay, so what you mean by megaloblastic anemia is the anemia that is caused due to impaired DNA synthesis. Okay, why this DNA synthesis is impaired in megaloblastic anemia? Because of the deficiency of vitamin B12 and folic acid. Okay, so because of the vitamin deficiency, B12 and folic acid deficiency, the DNA formation in the hematopoietic precursor cells are not happening properly. So it will result in the formation of megaloblastic anemia. Now, in a peripheral blood smear means you take the blood from the patient and you smear it in the glass side and stain it and look at it under the microscope. You will be able to see cells like this. Okay, so these are the RBCs. The red color one are the RBCs, and the one with some parts or lobes like this, they are the neutrophils. Okay, and this is the lymphocyte. Okay, so the characteristic feature in the megaloblastic anemia is hypersegmented neutrophils. Okay, normally a neutrophil will have like 3 to 4 lobes. Okay, lobes means like an enlargement like that will be seen inside the neutrophils. Normally 3 to 4 lobes will be seen. But in case of megaloblastic anemias, usually 5 or more than 6 lobes like this can be seen in the neutrophils. Okay, so that are called as hypersegmented neutrophils. Now, this is about neutrophils. Okay, now let's have a look at how the RBC will appear under this megaloblastic anemia. So the RBC, it will be usually very big, just like the name suggests, megaloblast. Okay, it will be a mega size. Okay, megaloblast and hyperchromatic. Increased red color will also be there. And then there are like special bodies present, which are called as Howell-Jolly bodies will be present and Cabot rings will also be present. So let's have a look at what these Howell-Jolly bodies and Cabot rings are. So RBC is a cell without any DNA. Okay, RBC doesn't have the DNA. Okay, so if some kind of residual during the maturation, this DNA is getting disappeared from RBC. But if some kind of nuclear DNA persists in the RBCs, then it will form blue color bodies like this in the RBCs. Okay, so such bodies are called as the Howell-Jolly bodies. Okay, so these Howell-Jolly bodies, you'll be seeing it in megaloblastic anemia and in post-splenectomy patients also. Then let's have a look at what these Cabot rings are. Okay, so in the Cabot rings means 8-shaped rings or ring-like structures that you see as inclusion bodies in the RBCs. They are called as this Cabot rings. Okay, so this also you'll be seeing megaloblastic anemia and in case of lead poisoning. Okay, so in the question, it was asked which of the following findings is seen in red blood cells in megaloblastic. Okay, so in the red blood cells, in megaloblastic anemia, you will be able to see only Cabot rings. Okay, so let's have a look at the other option. what is macropolycyte. Okay, macropolycyte are leukocytes only, especially the neutrophils with a greater diameter. Okay, very large neutrophils that are seen in pernicious anemia and in myelodysplastic syndromes. Yes, that are called as the macropolycytes. Okay, then the next option was Dolly bodies. What are Dolly bodies? Dolly bodies are again the cytoplasmic inclusion bodies. You see are like small round oval patches of inclusion bodies in these neutrophils. Yes, they are called as the Dolly bodies. Okay, then next one is the Dutcher bodies. Okay, so these Dutcher bodies are seen in plasma cells. It is the immunoglobulin inclusion in the plasma cell. They are called as the Dutcher bodies. Okay, they are very similar in appearance to Russell bodies, but they are not Russell bodies. These are the immunoglobulin inclusions that are seen inside the plasma cells. Okay, so if you look at the options itself, macropolycyte is a neutrophil, Dolly bodies are seen in neutrophil, and Dutcher body is seen in plasma cells. Okay, so the only thing that you will see in red blood cells is Cabot rings. Okay, so even if you are unsure about where these Cabot rings are seen, remember that these Cabot rings are seen in the RBCs. All the other bodies that you mentioned here that are not seen in the RBCs, they are either seen in the WBCs or in the plasma cells. Okay, it's a very easy way to get to your answer. The next question. The genotype in a patient with Turner syndrome is, okay, genotype. Yes, Turner syndrome. Turner syndrome in a normal female, usually the chromosome karyotyping, if you look at it, there will be like 22 pairs of chromosome with one sex chromosome. Okay, so totally it will be 46 chromosome plus one sex chromosome. Okay, so in the sex chromosome, the X will only be there for a normal female. Y will not be there. It will be XX, 46 XX. That is the normal genotype of a female. But in case of Turner syndrome, what is happening is that in the sex chromosome, there will be absence of one X. Okay. Or even if the X is present, it will be highly inactive. Okay. So that will lead to a syndrome that is called as Turner syndrome. Okay. So the karyotyping of a female who has Turner syndrome will be 45X. Okay. This 45X. Okay. Only one X chromosome is missing. So totally we have 45 plus X only. Okay, the X, or in some in journals and textbooks they had used 45XO. That's also right only, 45X or 45XO. Okay, so it will result in something called as short stature, low posterior hairline, webbing of the neck, and heart diseases like coarctation will be seen, broad chest, and infertility, amenorrhea, and very rudimentary ovaries are all seen in case of this Turner syndrome. Okay, like that, you should know about Down syndrome and Klinefelter syndrome also. At least the most prominent ones. Okay, the most common ones, you should at least know about it. Okay. So that's all about today's discussion. I think that's too much pathology for one day. In case if you have any doubt, you can ask now, or if you are not remembering the doubt, then you can put us a comment below this video. We will definitely answer all your queries. So all the best for your preparations. Do well, keep studying, keep revising, and keep doing MCQs regularly also. Okay, so stay safe and take care. Good night and goodbye.